Nomataminastak. I'm Dr. Tamina Wedder from North London. I'm going to be talking about chest X-rays and CT chests. Could I just confirm that everybody can hear me?
Yes,
Yeah.
everybody can hear you.
Okay, that's great. And you can see my slides?
Yes, exactly.
Okay, brilliant. So I'm going to go through mostly chest X-rays today, and then a little bit of CT chest at the end. From my understanding is that there's a lot of final year medical students and first and second year doctors. I hope I'm correct, because that's what I've geared it towards. And obviously, if you've got any questions, please do let me know, either in the chat or at the end. So the aims for today, I'm just going to go through chest X-ray basics. There's a lot to go through in chest X-rays, and I've been told I've got about 45 minutes. So I'll try and get through as much as I can, and I'll go through the structured approach that I have with going through a chest X-ray and how I would approach presenting it and going through it to make sure that I don't miss anything. Also, common pathologies that you will find on a chest X-ray that I think you're going to be able to find useful, and hopefully we can have some interaction there where I can get some people to present. I know that's not always the nicest thing, but it would be great if we could have some interaction. There's nothing too difficult on there, but things that you're going to see on your day-to-day practice. And then we'll go through CT chests, sort of the basics and the anatomy. I think for your level, CT chest is quite a complicated and more in-depth topic. So I'm going to leave that to sort of just the anatomy and the basics that I would presume a final year medical student would want to know, and then just some spot cases. So obviously, if you're able to interact and if people are able to present, that would be great, okay? We're all here to learn, and we're all here to learn from each other, so there's no mistakes that can be made or anything, okay? So if we start off, chest X-ray is very common. It's going to be something that you'll use throughout your career. Starting off as a medical student, you'll be asked about it on your rotations, on your rounds, and even going up all the way to your consultancy, it's always going to be something that you'll use. And it's a great balance between diagnostic usefulness and radiation. It's not that much radiation dose, and you can glean a lot of information from a chest X-ray. So being able to interpret it well is always very, very useful. What I would say is at your stage is to try and focus on identifying what's normal. So once you are able to get this right and be able to confidently say that this is a normal chest X-ray, then picking up the pathology becomes a lot easier in that sense. So I'd start off with trying to see as many chest X-rays as you can and trying to present them in a systematic approach to make sure that when a pathology does come up, you don't miss it. So you don't necessarily need to know what's wrong. You don't need to have to come up with a diagnosis straight away. What you need to do well is to be able to describe an abnormality and really be able to present it to someone else as though they don't have the chest X-ray in front of them, but you're able to present it in a way that they can imagine the chest X-ray in their minds. When you start presenting a chest radiograph, I would, obviously, if there is something very glaringly obvious, I'd state the obvious abnormality, and then I'd go back to using a structured system to be able to glean through the remainder of the X-ray. So this is the sort of approach that I use to look at all chest X-rays, and I use the acronym RIPABCDE. So I remember it. So, you know, obviously in an exam setting or if you're on a ward round, things like that, you'll forget things. And it's really important to not miss any of these key things on a chest X-ray. So just having that mnemonic in your head can get you to sort of run through it at any time. So if you get stuck, you just go through the mnemonic. So your rotation, very important. And I'll talk to you about how you can check for rotation, but essentially you're looking at the medial ends of the clavicles and the spinous processes of the vertebra and seeing whether they're in line in the middle, and if they're not, which way they've rotated to. So if the spinous process is closer to one side of the vertebra, then it's rotated towards the other side. Your inspiration, so counting how many anterior chest ribs that you can see. If they've got a good inspiration, you should be able to see at least 6 anterior ribs. And penetration, so can you see the vertebral bodies pretty well through the heart? Is it well penetrated? So all of that will tell you if this is an adequate film. And then I go through the different areas of the chest X-ray. So I always start with the airway and talk about whether the trachea is central. And then you go to the lung fields, and there are different lung zones. So upper, middle, and lower zones, and you just see if there's any abnormalities, any asymmetry. Is one smaller than the other than it should be? Is there anything glaringly obvious within the lung zones? Cardiac, so looking at your left and your right heart borders, heart size, and anything that you can see that's abnormal within the heart. Diaphragms are obviously very important, being able to see so someone's just told me to switch to full screen. How do I do that? Is it my slideshow? Is that better? I hope that's better. So we've done cardiac, going to diaphragm, looking at the contours of the diaphragm, looking at the edges at the costophrenic angles, seeing if they are blunted in any way, if you can see if there's any obscuration of the costophrenic angles or any part of the diaphragm, you're looking at pathology there. And then E, so I just remember E is everything else. So make sure you look at the soft tissues. Is there any surgical emphysema in the soft tissues? Are they missing a breast, for example? Bones, are there any chest, are there any rib fractures, any humeral fractures that you can see? Can you see bony mets everywhere? There's so much to be gleaned from all of the other things. And then under the diaphragm. So we'll go through the kind of things that you can find under the diaphragm. So just looking at the chest X-ray anatomy. I was wondering if people could just shout out what those 1, 2 to 10 is, but obviously it might be quite simple for you. Actually, I'll just go through it. So number 1 is your trachea. Number 2, your hilar. This is obviously very simple for you guys. Number 3, your anterior ribs. Number 4, your hemidiaphragms. Number 5, the heart. This is especially the left heart, the left side of the heart. Number 6, the aortic knuckle, the aortic arch. Number 7, pleura. I think that's what it's pointing to. Number 8, your scapula. And number 9 is breast shadows. And then these are the areas of the lungs that you split into. So corresponding to the different zones in the lungs. So essentially, what is a chest X-ray? A chest X-ray is passing a beam of X-ray, and what you get on the radiograph is essentially a range of colors of between white, gray, and black. And it's about the penetration of how dense the material is and how much of the X-ray beam it's allowing to penetrate. So if you've got air or gas, such as the lungs, it's going to be quite black, and soft tissues get a bit more gray. Bone becomes a lot more white, and then metal.
Sorry, Dr. Saiba, عزيز لطفا مايكاي شما ميوت كونين لطفا مزاحمت ما كونين. Dr. Saib Tahmina, can you mute all? There is option, click on participants and mute all participants.
Oh, okay. Let me try that.
Yes.
Where do I do that?
Yes, now all are mute. Rahmat Khan, please mute your mic.
So there's obviously a PA chest radiograph that we do, and also there's the lateral chest radiograph. So in the UK, we don't really do the lateral too much, but I don't know if in different parts of the world, they will probably do things differently. And there's still a lot of information to be able to glean from a lateral chest X-ray as well. So I've just put this slide up to just run through the anatomy to be able to see what you're seeing on a PA and how that corresponds to a lateral chest X-ray. I think you'll all be getting the slides as well, so that hopefully you'll have that for reference. And you've got your PA or an AP. So your PA chest radiograph is your normal, typical radiograph. And then an AP is more for your unwell patients that aren't able to stand and have a normal penetrating from the front to the back chest X-ray. From the back to the front, sorry. Why does that matter? Well, I think it matters in terms of interpreting things, because if you've got an AP, your patient's unwell, the beam of the X-ray has switched around, then your cardiothoracic ratio is going to be different. And when you want to look at whether the heart is enlarged, you won't really be able to reliably say that on an AP because of the whole distortion of the mediastinum. So, like I said, after I've gone through the whether it's an adequate film, then I always look at the airway and whether there's any tracheal deviation. And why do I do that? Well, actually, there's so much information to get from that. Is the trachea deviated because something is pulling it, or is it deviated because something is pushing it from the other side? Pulling forces, there's so many causes that it can be, and if you just run through them in your mind when you're looking at a trachea that's deviated, then you can sort of put all your things, all of the pieces of the puzzle together when you're looking at chest X-ray. So pulling forces could be collapse, fibrosis, pneumonectomy, a mass or a tumor could be pulling the trachea that way. And then your pushing forces, so if you've got lots of air or lots of blood or a big solid mass, that would push the trachea over to the other side. And then sometimes you can have pathology on both sides of the chest X-ray, and that will cause two opposing forces, and that will essentially mean a central trachea. So then next you'd be looking at the lung parenchyma. So what you see on a chest X-ray, if you see an abnormality, is it sort of quite white and more fluffy? Is it consolidation? Or is it sort of lines and more fine opacities, and is that interstitial? Nodules are just small lesions that you can see in the lung, and then a mass is bigger lesions. So essentially you're describing what you can see. So can I see consolidation, interstitial changes, a nodule because it's small, or a mass because it's large? So does anybody want to present this chest X-ray for us? Just in the kind of way that I've described, so RIP, ABCDE. Does anyone want to have a go? Yep, Dr. Amnagul, please go for it.
Gentlemen, is this slide should I present?
Sorry, I couldn't quite hear you very well. Do you want to just speak a little louder?
Now it's clear?
Yeah.
Okay. I will try to describe.
Sure. Just go through your system. That's fine.
Okay. If we look at the start of the X-ray, then it should be taken in if I am not wrong, it should be in posterior anterior, and there is the clavicle bones that are visible. If I'm not wrong, I'm just a little bit confused. And the lungs are more dark, and the backbone is a little bit it's visible to show. And if we can say the left side is the diaphragm is little higher than that of the right side one, and there is normal cardiothoracic ratio. If we can see, heart is it's normal size. There is no problem with them. And in the upper side we can see the aortic arc as well, and as well the scapula are little bit visible. Thank you.
That's great. Excellent. So in summary, what would you say about this chest X-ray? Is it normal or abnormal?
It's the normal chest X-ray.
Brilliant. Yeah, exactly. So I just started off with a normal chest X-ray, and that was great. You went through a system, and whatever system works for you, you don't have to stick to the one that I've said. But yeah, absolutely right. Going through the lung zones, going through the heart, going through the bones afterwards. You mentioned exactly. So this is a normal chest X-ray, and the more you practice presenting a normal chest X-ray and being able to recognize a normal chest X-ray, the easier it will get to pick up anything that's abnormal with it. Okay. So hidden areas. These are the areas that usually pathology is very easy to be missed. So these are areas to look out for. So when you are looking at a normal chest X-ray and you're thinking, okay, this is normal, let me just double check the hidden areas to make sure that I've not missed anything. So for example, the apices, right at the top, it's very easy to miss something small up there. A little bit of pleural thickening or some nodules in the apices that could indicate TB, for example. It's very easy to miss. So I always have a quick look at the apices again after I've looked at the lung fields. Behind the heart, so obviously you've got your heart shadow, but then you've got the vertebra there as well. So it's quite easy to miss any subtle opacities with that behind the heart. So I would always go back and just check. So the side, look at the right side of the heart and the left side of the heart and just see whether the opacity is kind of the same on both sides. If one side is more opaque than the other, then just think, is there something going on behind the heart? Behind the diaphragm, remember the posterior aspects of your lungs go all the way down. So you've still got lung behind the diaphragm there. So just have a glimpse behind the diaphragm and think, is there anything going on there? I look around at the pleura just to see that there's no pleural thickening, any pleural plaques that you can see. Sometimes you can miss small sort of pleural masses because it kind of blends in with the ribs. And also very, very small pneumothoraces. Once I go through the pleura, any small pneumothoraces you could pick up just by making sure you look around there. Bones. Important to look at bones because there's a lot of bones on the chest X-ray, and there's so much that can be picked up. So if you've got a patient with sort of subtle metastases on the bones, that's already giving you a lot of information. Have they got multiple rib fractures? Is it a flail chest? And then the soft tissues. So again, so much can be told from the soft tissues. Are they a very, very slim person? Are they cachectic almost? That will point you towards more of pathology. Have they had a mastectomy and there's only one breast shadow? The surgical emphysema, so have they had trauma? Have they had intervention? Is there a chest drain in there? Things like that. So it's always important to, once you've done and looked at it and it's a normal chest X-ray, go back and look at the hidden areas. So does somebody want to present this chest X-ray?
Can I?
Of course, go for it.
Okay, I think it's also a normal chest X-ray, if you see like to see to trachea, trachea is like located in normal position, and also aortic arch is normal and heart size is normal again. We can see we are able to like see cardiac phrenic angle to it's not blunt. So I think it's zoom. I can see post phrenic angle. Is it blunt or not? So we can see scapula, clavicles. That's all normal. I don't know more about it.
Okay, that's great. That's great. So I like the system.
I think consolidations X-ray.
Sorry, what was that?
Consolidation.
Okay, where do you think there's consolidation?
In apex.
Yeah, brilliant. That's very good. So I like the system that you went through, looking at the lung zones, looking at the heart. You mentioned well that the costophrenic angles you cannot see. Obviously, this is not an adequate film. But in terms of the thing that's most obvious is that there is opacities within both apices. And again, if you don't go through the hidden areas, you could easily miss that, because there is so much going on in the apices. You've got your first rib, you've got your clavicles, your manubrium, the big vessels. There's a lot going on up there, and it's easy to miss opacities. But yes, exactly. There are bilateral opacities within both lung apices. And so that could be consolidation, and that could be masses. Anything that I see in the apex, I always think TB. So this example in particular has been TB. This is a TB case. But I'd also look right at the top of the pleura, see if there's any scarring, anything like that. But yeah, very good, very good. Does somebody want to do this one?
Is it a pleural effusion?
So why don't you do a sort of system? Try and present it in some sort of system, and then we can go through the differentials. Is that okay?
So I think so we can not able to see the right side diaphragm, and also costophrenic angle is blunt. So we have also other parts are normal, like trachea, clavicle, scapula. We have some consolidation in lower loop. So that's why we can say is a pleural effusion, I think.
That's great. That's great. I like that you went again back to that system. What I would say about this chest X-ray is, or any chest X-ray that you're presenting, is try not to jump straight to the diagnosis. So when I said at the beginning, describe the most obvious abnormality and then go through the rest of the chest X-ray. So what I mean by that is describe it. Don't jump to, give yourself time to be able to come up with a differential, but when you're describing it, you don't need to come up with a diagnosis. So I would describe this as there is an opacity within the right mid to lower zones obscuring the right costophrenic angle. What else it's obscuring is I can't really see the right heart border on here. And because I can't see the right heart border, I'm thinking there might be some consolidation going on around there. So yes, this is probably going to be consolidation with possibly a pleural effusion as well. It's hard to tell on a chest X-ray, but all you can do is describe it and then say that. So yeah, that's great. So that takes me nicely onto the silhouette sign. So a silhouette sign is a sign that we use to try and locate where an opacity or consolidation is within a chest X-ray. And the different places it could be will tell you what lobe it's defined. So if you've got obscuration of the left hemidiaphragm, so there is an opacity and you can no longer see the crisp outline of the left hemidiaphragm, then there is consolidation within the left lower lobe. If you can't see the right hemidiaphragm because of the consolidation, then it's going to be the right lower lobe. If the left heart border is obscured and you can't see that crisp line of the left heart border, then the consolidation is within the lingular segment of the left upper lobe. Just because you have to think about the lungs are a 3D structure, and this is we're seeing it on a 2D image. And if you've got obscuration of the right heart border, then that's the right middle lobe. So if I go back to this one, we can see the right hemidiaphragm pretty well. Like you can see a nice crisp line. So this isn't consolidation within the right lower lobe. Otherwise, we would have lost that. But what we can't see here is the right heart border. So that's telling me that there is consolidation within the right middle lobe. And that gives you a lot more information as to where about the pathology is. So consolidation, or what do we mean by consolidation? Essentially, you've got something blocking the X-ray beams from hitting the X-ray plate, making it appear more white. Now, what could be blocking it? Any number of things could be blocking it. It could be fluid, it could be pus, it could be blood, or it could be cells from a tumor. And you won't be able to really tell on a chest X-ray. Classically, if you describe something as consolidation, it does refer to a pneumonia, but that's not always the case, and it's difficult to be able to say that with any level of certainty just because of what consolidation means on a chest X-ray. So it could be malignancy, it could be pulmonary hemorrhage, most likely it's going to be infection, but it could be infarction of the lung, edema, and what you want to see to be able to say it's more likely to be infection rather than something else. Is it ill-defined, so not completely opaque, but sort of ill-defined, patchy? Are there air bronchograms? So can you see airways through the whiteness and no volume loss on that side? Then you're most likely going to be a pneumonia. And is it confined to a lobe, or is it multifocal? Or is it diffuse everywhere? So what I mean by air bronchograms are these. So although you can see a sort of an opacity within the left mid zone, you can also see that it's not completely white. The lungs are still the same size on both sides, so you've not lost volume. And what my arrow is pointing to are airways. There are airways that travel within the opacity. So this will tell you that it's most likely going to be a pneumonia. Does somebody want to present this chest X-ray?
Is it, teacher, a pneumothorax?
Yeah, that's great. So obviously this one is blindingly obvious.
I jumped again for diagnosis. I think that the left side is more blackened than right side. We can see it's more black than, that's why I can see it's a pneumothorax.
Yeah, exactly. And you know what, in this case, I would also jump straight to the diagnosis. It is a large left-sided pneumothorax. It's obvious. You guys are obviously very good. I probably gave you 2 easy cases, but this, what it means is that you've said it's a pneumothorax, but in terms of a pneumothorax, what then would you go on to look at to make sure?
So ear, sir, teacher, because I think we have more ear and right side, more blacker, more consolidation.
Yeah, so it's definitely more black on the left side. So that's all air, but with no vasculature there. But then you'd look at the trachea. You want to see if the trachea is still central, or is it being pushed across to the other side. And if it's being pushed across to the other side, you worry about a tension pneumothorax, and that's a medical emergency. Realistically, you should never be X-raying a tension pneumothorax, but once in a while it comes in. And I would say that this one is probably pushing towards a tension pneumothorax, so it would need to be treated immediately. You can also get hydropneumothoraces. So if there's blunting of the costophonic angle as well, then that could be blood mixed with air within that side. And then you'd always also look to see if there are any lines, any trauma. Why has this patient had a pneumothorax? Is it a spontaneous pneumothorax, or has there been trauma? And if so, then you want to look for any rib fractures around that area, any reasons for the trauma. Okay, that's great. So yeah, just summarizing what I said, you just look for lung markings. If it's completely black, it's going to be a pneumothorax. Check all the peripheries. Sometimes they're very subtle. Sometimes you can get apical pneumothoraces and it's very difficult to see. So that's where you go back to your hidden zones and look at all the peripheries. Check for any asymmetry, and then, like I said, look for the tensions because they're a medical emergency. Does somebody want to present this one? Again, just describe what you see, really. Yeah, go for it.
Okay, teacher, I should again explain it. So I think the teacher, trachea is in normal location, clavicle is normal. We can see aortic arch as well. And also in lungs, we have a lot of ear. So it's also both of lungs like have a lot of ear and consolidation with ear. So it's also, I think, a pneumothorax. And we are not able to see like costophrenic angle, so it's blend. And we cannot see lung marking as well. So
okay, that's great. So you've gone through again with your system, and that's really good. What I would say, I don't know if it might be the projection that you're getting from what I'm because this isn't a very good it's not a very good image, but if you look closely, you can actually see lung markings all the way to the edge, and together with vascular markings as well. So you can see lung all the way to the edge. So I don't think there's a pneumothorax, but obviously if you're seeing it very dark, you'd want to raise that as a suspicion. But I can see sort of lung markings all the way to the edge. But you're right, there's costophrenic angle blunting on both sides. And I'd probably say that the left is a bit more than the right. And so, yeah, this patient has got bilateral pleural effusions, which is great. It's well done for spotting that.
And also we have cardiomegaly.
Potentially, yes, potentially. So with cardiomegaly, you're always measuring the cardiothoracic ratio. And you can only really measure that on a PA radiograph. So making sure that they're standing and there's no distortion of the mediastinum. And there's not too much rotation. So there isn't too much rotation on this, which is great. The cardiothoracic ratio here, I haven't got a measuring tool, but if you kind of ballpark it, it's probably going to be just about 50%. Anything over 50% would be cardiomegaly. So this could be on the upper border of normal in terms of heart size. But yeah, so you'd be measuring the largest part, the largest width of the heart, and then the largest width of the thorax. And then that will be your ratio. And if it's more than 50%, then you've got cardiomegaly. So pleural effusions, again, could be blood, it could be pus, or it could be lymph. If you get a pleural effusion on one side and there's no obvious cause to it, so there's no, pneumothorax or major trauma, then you have to think about malignancy. Why have they developed a pleural effusion on just one side? And even if you've got small amount of blunting of the costophrenic angles, because this is a 2D representation of a 3D structure, and you've got lung that goes all the way back down into your recesses, then a chest X-ray can't really tell you how big it is. You'd be surprised how many very slight blunting, which makes you think it's a very small pleural effusion, can be quite a large pleural effusion. We also always try and think of pleural effusions as just the costophrenic angles, but you can get pleural effusions that go all the way up within the fissures and all the way up to the apices. So do make sure you look at it for pleural effusion. Okay, does someone want to tell me what's wrong with the chest X-ray on the right? What am I trying to show here?
In the left side, I think it's cardiomegaly, and in the right side, the left border of heart became decreased.
Okay, okay. I think I've got it the wrong way around. So I'm looking at the right. So you're probably thinking the right is cardiomegaly with all the white fluffiness around
Oh,
it.
no, left.
Left. Okay. And what makes you think that's cardiomegaly?
Because in left side and the left border of the heart is becoming increased. I think it's both shape.
Okay, okay. I like the way that you're thinking. Definitely, you can see a lot more of the left side than the right side, but I would probably say that's normal. So if you measured the width of the heart compared to the width of the thorax, I'd say that's probably going to be less than 50%. So I don't think there's cardiomegaly there. What I was trying to picture in this one is that there is an NG tube in both of these images, and it's important to look at the lines because sometimes the lines give a lot away. So the NG tube in the first chest X-rays, so the one on the left, is in the right place. So as you can see, it bifurcates the carina. So it's gone past the carina, it dives over towards the left side, and the tip is projecting over the stomach. But on the other chest X-ray, it's gone straight down the right main bronchus, which is the part of that's the easiest to go down because it's the more fatter and straighter one. And then there's a whole load of consolidation around there, which makes sense. They've probably fed through that NG tube that's been misplaced. And now they've got lots and lots of consolidation around there. So what I was trying to get with these chest X-rays was the lines are also important. So looking at have they got any NG tubes, any cardiovenous catheters within there, just any of the lines in the tubes that lots of unwell patients will have in. They can also give you an idea of what's going on. So it's important to be able to pick up that this NG tube is in the wrong place and it's causing all of this consolidation. So this is just describing what I just said. And does someone want to have a go at this one? And focus on the diaphragms for the interest of time.
Both costopharyngeals are open, but the right side of the diaphragm, the dome of diaphragm, is much more elevated than the left side. This much.
Yeah, yeah. Is there anything else that anyone spotted?
Can I jump to the diagnosis, teacher?
Yeah, go for it.
I think, teacher, is pleural effusion again.
Okay. Definitely on the right side, there's blunting of the costopharyngeal angle, so I do agree there. With your eye of faith, I don't know if you can see, but over here we've got some darkening. Can you see my scroller? That there's this is a bit darker than this bit, right? And usually we'd say that's okay, that's the stomach bubble, and that's fine. But you should never be able to see that on this side, on the right side, because there's no stomach bubble on the right side. So there should never be something darker under the diaphragm. And over here, you've got a nice crisp diaphragm here. it is a little bit higher, but we kind of expect the right side to be higher because of the liver. But there is a very dark line under it. And that, so remember, dark means air. So that means there's air under the diaphragm, which again is not a good sign. So you always need to pick this. It's very subtle. It's very, very easy to miss. But it's really important to look at it. So when you're looking at the diaphragms, you're not just looking at the costophrenic angles. You're seeing, is it crisp? Is there anything blunting it? Is there any air under the diaphragm? Because this is telling you this is a very unwell patient because they've got air within their abdomen. So it's a pneumoperitoneum, air under the diaphragm. And there's lots of causes for it. So perforated duodenal ulcers or sigmoid colons. If they've had surgery or endoscopy, you could also get some air under the diaphragm. So you need a bit of history. But obviously a perforated bowel is a medical emergency. So it's very important to pick that up and let someone know. This one is a lot more subtle. It's a lot, I think it's probably a lot harder, but does anyone want to have a go? I'm gonna tell you what it is, just because there's still a lot to get through. But what I'm looking at here is I'm looking at both of the HILAR, and they're just looking a bit more bulky, a bit more white than I would normally expect them. I wouldn't expect them to be this big on both sides, and it's just looking a lot more white. So I would say that there's bilateral HILAR lymphadenopathy here. And HILAR lymphadenopathy, you're probably going to go through in a lot more detail with pathology, but you basically want to know, is it on one side or is it on both sides? And then your differential diagnosis for that. So if it's just on one side and you've got a bit of consolidation, think about infection, or is there a tumor that's just spread to one side of the lymph nodes? But if you've got consolidation on both sides, you're more likely to be thinking about things like sarcoidosis, tumors, but more likely metastases or lymphoma, and then rarely your TB. TB can be unilateral or bilateral. So we've gone through a lot of the chest X-ray now. And does anyone have any questions before we go on to CT, which I'm going to go through very quickly? We can ask, if you have any questions, you can save it for the end. And I will get back to them.
Dr. Saibano, kacheta the X-ray marbut suk pachtana larino us warta huwa hai.
Oh, I don't speak.
Sorry, what's the key point for diagnosing of sarcoidosis?
Sarcoidosis,
Yes.
I think one of the key findings would be your bilateral HILAR lymphadenopathy. That would be one of the first things that you'll pick up on with sarcoid. And that's before the lungs get affected so much that you will see it on a chest X-ray. So if you see bilateral HILAR lymphadenopathy like this, so you've got the lymph, both sides affected, what you're going to do realistically is you're going to send this patient for a CT chest. And on your CT chest, you'll find the subtle changes within the lungs that could tell you this is sarcoid. But in terms of just on a chest X-ray, pretty much the bilateral HILAR lymphadenopathy will point you towards that.
Thank you so much.
No problem. So CT chest, CT chest in the UK is quite specialised. It is very complicated to be able to go through a CT chest, and I don't think any junior doctors or medical students would be expected to be able to go through it in any form of detail. But I think knowing the basic anatomy of it and what you need, the basic findings on a CT chest is important. So what is a CT chest? So it's actually just multiple X-rays taken of multiple slices through the body, and you're creating cross-sectional imaging through various software. It's very high definition imaging of a lot of structures to go through. And a lot of it is going to be beyond the scope of this lecture. I've got about 10 minutes to cover the majority of CT chest. But what's important to know is that a chest X-ray gives you 0.1 millisieverts of radiation. a chest CT gives you 7 millisieverts. So you are getting 70 times the dose of radiation that you would get for a chest X-ray. So it's like giving a patient 70 chest X-rays for one CT chest. So it's important to make sure that you are requesting a chest CT appropriately. You're not going to give it to everybody. You're going to give it to someone who you really think has got pathology, and that's why your chest X-ray is your friend there. Again, a good starting point is to just be able to identify normal and going through the anatomy. So there are different types of CT chests. You've got your non-contrast CT chest, and this does give you information. You'll be able to see the lung parenchyma fine, but you won't be able to see the subtle differences within the soft tissue, as you would with a CT chest with contrast. You're giving contrast, obviously, within the vasculature. Contrast just basically enhances certain soft tissue against each other. And so you're able to pick up subtle malignancies and, any small lymph nodes, anything like that, you'll be able to pick up because they've got contrast. There are obvious reasons that some patients can't have contrast and you'd have to go for a CT non-con, such as if they've got renal failure and their renal function is really bad, then you just wouldn't be able to give them contrast. So you are able to do a non-contrast scan. We've also got high resolution CT chests, and a HRCT is always requested usually for any suspicion of fibrosis, because you'll be able to see that so much better with the resolution quality of a HRCT. And then you've got your CT pulmonary angiogram, so your CTPAs, and you're requesting a CTPA if you've got any suspicion of a pulmonary embolus. And it's important to know the differences and why you're requesting it, because actually a HRCT is not great at looking at other things, because it's a non-contrast scan. So if you are looking for malignancy, you're not going to really be able to see it very well on a HRCT. And if you're looking for a pulmonary embolus, well, you're not going to be able to see it on a non-contrast scan at all. You need the right amount of contrast and the right protocoling to be able to see it within the pulmonary vessels. So starting off on a CT chest, you guys probably know this, but you need to get your orientation right. So essentially your image is back to front, and you're looking from feet upwards. And your CT views, you're always going to get 3 views. So the view I always look at first is your axial planes, and then you can get your coronal planes and your sagittal planes. So it's important to know which view you're looking at. So CT chest anatomy, I'm not going to go into too much detail in it, but these are essentially the different lung lobes, and you should be able to know that when you're scrolling through a CT chest. And then on your coronals, it's important to know the major vasculature and the major structures. So your right atrium, left ventricle, left atrium, where your pulmonary trunk sits, where your superior vena cava sits, where the aorta is. And it's easier because you can scroll through it, and you can see the relationships between each of them, so you find them easier. So the next couple of slides that I'm going through are essentially the anatomy, and I'm not going to, just because of time, I'm not going to go through them in too much detail, but you will have these slides to just recap on all this anatomy. So these is just all the anatomy of this CT chest, the important parts that you should be able to recognize. It's basically the major blood vessels, the heart, and the various different lobes of the lung. And then just a couple of spot cases. Does someone want to tell me what the obvious abnormality is? It's okay if you can't, because obviously
Teacher, I think it's a normal chest X-ray, CT scan.
Yeah.
I'm sorry.
Okay, that's fine. It's obviously very hard because I'm just giving you one slice. There are hundreds of slices in a CT, but if you can see my scroller, there's contrast within this vessel, the pulmonary trunk, and the contrast is all there, but you've suddenly got black bits here. So this is a large pulmonary embolus. But like I said, I think this CT chests are quite specialized for your level. Here is an example of consolidation. So it's a bit like the chest X-ray. It's white, but it's not completely white. You can still see sort of air bronchioles, airways through it. And this is how you know that this is consolidation due to infection. And then this one is an example of florid fibrosis. It's a HRCT, florid fibrosis, most probably idiopathic interstitial fibrosis. And then this is very, very white opacities that are across both sides of the lungs, various sizes, quite round, and we call these cannonball metastases. Or you'll have a single opacity, which is quite white again. No, you can't really see that many vessels going through it, and it's not patchy. So this is a single malignancy within the chest. I've just put some resources that I think you guys might find useful. They're just free websites that we use for our teaching that explains chest X-rays and CTs in pretty good detail. So Radiology Cafe. So if you Google any of these, they come up as websites, and there's so much information to be able to get from there, and they're very useful. And I found it useful as a medical student, as a junior doctor, and now as a radiology registrar. They're just very, very useful. So if anyone wants to have a look at them, they're there. But that's it. That's my whistle-stop tour of CTs. Hopefully you find it a little bit helpful. What I really want you guys to take home from this is being able to get a systematic structure to your chest X-ray interpretation and just knowing your anatomy well for the CTs. Any questions?
Teacher, I have a question.
Of course.
Okay. Teacher, how you can differentiate it between cyst and OPSE in a CT scan is my big question that I have always, and I can differentiate it. OPSE and cyst.
Between a cyst
abscesses, as you know. OPSE.
Right, okay. An abscess, is that what you mean?
Yes, exactly.
Okay, so with a CT scan, you've got different density levels. So you've got your Hounsfield units, and that basically helps you differentiate between air, lung, fluid, water, blood, soft tissue, bone, and it's the grayscale. But what that means is if you've got a contained opacity in your lung on a CT scan, and you're trying to work out, is this filled with uniform fluid? So is it just a cyst, a normal cyst, or is it filled with heterogeneous fluid? Is it an abscess? Then you're going to use your Hounsfield units. You're going to check the number on those. So if it's going to be a cyst, it's going to be very uniform, the same number throughout on a fluid level. But if it's an abscess, it's going to be heterogeneous. You'll get various different numbers because you'll get some solid bits and some liquid bits, and they'll have a higher Hounsfield unit than just water or just fluid. Does that make sense?
Yes, teacher. Thank you so much.
ډاکټر صاحبانو که څوک پښتنه لري لاس جیک کوي بیا به یو ته وخت ورکوو هغه به کوي نو کوېشن په هغه کې لیکئ میسج کې نو دی په ځای لاس جیک کوي او نورزیه بابري پښتنه لري مایک انمیوټ کوي او تاسو خپل کوېشن وکړئ. Thank you.
Assalamu alaikum. Thank you so much, Dr. Tahmina. It was very comprehensive and interesting lecture. My question is that before you mentioned that CT scan has a high resolution, do you recommend CT scan for old and weak people or not? Thank you.
For all, sorry, was that, I missed the last bit, for all?
For old and weak people, weak.
Okay, yeah. I would always start off with a chest X-ray. you can get so much information from a chest x-ray and with far less radiation dose. You also wouldn't need to have specialist interpretation of you guys, anybody can really interpret a chest x-ray and see what's mainly going on. Is this cancer? Is this an infection? Is this an emergency? You can get all of that information from a chest x-ray, whereas if you're going to request a CT scan, you need the patient to have good renal function, and generally when they're old and unwell, they're not going to have the best renal function, and you don't want to give them that dose of radiation or that dose of contrast. And at the same time, you also need a very specialist review. You'll need a radiologist to actually interpret that CT chest because they are complicated to interpret. And so in the first instance, before requesting any CT chests, I would always do a chest x-ray. It's just so easy, quick, and gives you a lot of information. And then from that chest x-ray, you can decide why you want to request a CT. And in most instances, if you're worried about pulmonary embolus or malignancy, or trying to differentiate what the consolidation